Hello dear students, welcome back to my YouTube channel Physiology Learning. Today we are going to continue with our ECG series, and in this video we are going to understand what are the ECG findings in Wolf-Parkinson-White syndrome. This is not a very common syndrome, but sometimes the findings in the ECG are so classical that can be asked in a multiple choice questions. So that is why this topic is important. So basically, you might not be seeing the case of Wolf-Parkinson-White syndrome in your lifetime, but still the ECG findings themselves is very classical. And since we have already done a lot of our basics, so this will be easier to understand the ECG findings of this particular syndrome. So let's try to understand what happens in this Wolf-Parkinson-White syndrome. So this was named behind three scientists. Three of them contributed for this syndrome by identifying it. That is Wolf, Parkinson and White. There are three different people who have contributed together for identifying this type of syndrome. So all of us know the conduction system, which we have already done it. First we have the SA node, then we have the AV node, then here we have the AV node, then the bundle of His, then we have the right and left bundle branches, and finally the Purkinje fibers. So this we have already done it. This is the conduction system. So AV node, one classical feature of this AV node is nothing but it acts like a one-way conduction. So whatever impulses that has to travel from the SA node to the ventricle, they will always go through with the AV node. And if the AV node does not conduct, then it will become a conduction block. Generally, the impulses from the atria, suppose the atria is getting depolarized, but it cannot be directly transferred to the ventricle. Why it cannot be directly transferred to the ventricle? Because in between the atria and ventricle, there is a huge fibrous tissue, and this is not going to conduct any of the impulses which are forming in the atria into the ventricle. This is not going to happen. But in case of Wolf-Parkinson-White syndrome, what is going to happen is, first we will try to understand what happens in this person. What is the abnormality? The abnormality in this person is there are some abnormal fibers which are connecting both the atria and the ventricle. Ideally they are separated, but here some fibers they are connecting the atria and the ventricle. So now the SA node is firing and the AV it is coming to the AV node, and all of us know that AV nodal delay will happen so that the atria can contract and empty its blood. But right now the AV node has received the impulse, but it is keeping the impulse with itself. But at the same time, there is lot of depolarization happening in the atria, and because of this fibers, this depolarization can be conducted into the ventricle even during the AV nodal delay period. So what will happen? The impulses from the atria immediately go to the ventricle and they start depolarizing. And after some time, what will happen? After the AV nodal delay, the impulses from the AV node also reaches the ventricle. So we have understood the pathology now. Now we will try to identify what happens in the ECG. So I will keep on putting you the question, so you keep on thinking and you can answer it by yourself also. So first one is, will there be any abnormality in the P wave? No. Why? Because the P wave is the atrial depolarization, and here the atria is getting depolarized properly, so the P wave is going to be normal. Then after the P wave, one segment is to come which is called PR segment, and all of us know this PR segment is due to AV nodal delay. But AV node is delaying it. But what is happening? The impulses from here are going through this fibers or the bundle from atria to ventricle. So this will shorten the PR interval because some of the impulses have already reached the ventricle. So once they reach the ventricle, what they will start? They will start depolarizing the ventricle and start the QRS complex like this. Now again the impulse from the AV node, after its delay, it will reach the ventricle. So what will happen? Again a proper QRS complex will be formed like this. So what has happened in this ECG, and will the T wave will be normal? The T wave can be still normal. So where is the main abnormality? Is in the PR segment and the QRS complex. So there are three classical findings which they can ask you in an MCQ. What are the changes in Wolf-Parkinson-White syndrome? They can ask you all of the changes are in Wolf-Parkinson-White syndrome except also. So here what has happened? The PR interval is shortened. So this is one first feature, that is nothing but PR shortening. So the PR interval or the PR segment, we can say it has shortened, it has reduced in period. Both the segment, if the segment is shortened, obviously the interval also will be shortened. So PR interval shortening. Second thing is, since the impulses have reached the ventricle earlier, there is a generation of this type of small elevated wave. This has been given a special name called as delta wave. Delta wave. So second finding is the generation of delta wave. And the third one, as you can see here, because of this delta wave generation and the original impulse reaching the ventricles, there is widening of QRS. So the third one is widening of QRS complex. So these are the three classical ECG findings. You will find it in a Wolf-Parkinson-White syndrome. And this bundle has a special name. That bundle is called as bundle of Kent. And sometimes there will be multiple bundle of Kents also rather than one bundle. So that also can be there. And usually the treatment for this is ablation of the bundle of Kent can be done. Generally, sometimes the patient might not be symptomatic also, but what will happen is in some cases, because of this bundle, there can be re-entry of impulses from the ventricle into the atria also. And this re-entry will depolarize the atria again and again, and they can have the potential to generate arrhythmias. So then it becomes dangerous. Normally, sometimes the bundle of Kent, when the impulses are coming, there is a widening of QRS complex, but the patient might be non-symptomatic also. But when this re-entrant phenomena starts to happen, the arrhythmia potential starts to generate, it becomes very dangerous for the patient. So it's a very simple topic, but the classical findings can be asked in your questions. So I hope it's clear. Thank you for watching the video. We'll see you in the next video. Thank you so much.